recorded.
Okay, welcome and thank you for joining us today for the meeting of New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Before we proceed, I would like to acknowledge a moment of silence in honor of Mr. Bernard Rosen, who passed away over the weekend. Mr. Rosen's commitment to HHC was unquestionable. He served on the Board of Directors from 1998 to 2019. That's 21 years. We honor him and his years of services. Thank you. So please note for the record that Dr. Michelle Morse is representing Dr. Ashwin Vasan and Karen Saint-Hilaire is representing Gary Jenkins, both in a voting capacity. So next on the agenda is the adoption of the minutes for the board meeting held September 29th, 2022. Are there any questions, comments, or changes? To accept the minutes? Take a vote. Deputy Mayor and William Sison?
Yes.
Yes. Dr. Calamia?
Yes.
Karen Saint-Hilaire?
Yes.
Michael McRae?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Salina Pinheiro? Frida Wang?
Yes.
Anita Kawatra?
Yes.
Michelle Morse?
Yes.
Yes. Patricia Martone?
Yes.
I'm missing. So the minutes have been approved. Thank you so much. So during the executive session, the board received and approved oral and written governing body submissions from NYC H&H Coney Island and Seaview Nursing and Rehabilitation Center. The board received and approved the 2021 Performance Improvement Plan and Evaluation written submission from Sydenham Diagnostic and Treatment Center, Gotham and Rehabilitation Center. The board received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospitals Lincoln, Henry J. Carter Specialty Hospital, and Henry J. Carter Nursing Facility. So thank you, Ms. Hernandez Pinheiro, for representing the board at the unveiling of the Ruth Bader Ginsburg Statue event. Do you have any feedback on the event?
It was a beautiful event. The new facility is magnificent. Every floor has virtually floor-to-ceiling windows. It's just inspirational. And the unveiling was beautiful. The presence of Ruth Bader Ginsburg's daughter was there. So that was really nice. It was very well attended. Yeah, it was a lovely event.
Thank you. I've seen pictures. I'm glad that you represented us at the event. So I actually also had the pleasure of visiting the radiology school at Bellevue with Mr. Peñamora, Ms. Pinheiro, and Ms. Wang and Ms. Lowe. That was on October 14th, and that was a very impressive visit. I'm glad that we were able to join the students there and learn more about the school, and so wonderful. We even got a note from the students basically saying thank you for the visit, and so if you have a chance to go visit the school later on, maybe not within the next few months, but at some point in the future, please do so. So they have to study. Vendex approval. Since we began the process of approving contracts prior to Vendex approvals, there are 3 items on today's agenda requiring Vendex approval. All have that approval. There are 2 items from previous board meetings pending Vendex approval. Since we last met, 3 approvals were received. We will continue to notify the board as outstanding Vendex approvals are received. So I'm going to move to the resolutions next. So let's begin with the number 2 on the agenda, which is adopting the name of the New York City Health and Hospitals Corporation, NYC Health and Hospitals Board of Directors and Implementation Strategy Plan prepared for each of NYC Health and Hospitals 10 acute care hospitals over 11 campuses, and for the NYC Health and Hospital Henry J. Carter Specialty Hospital and Rehabilitation Center as a supplement to the Community Health Needs Assessment, which was approved by the Board of Directors in June 2022. And this was presented to the Strategic Planning Committee on October 17th, 2022. Yep.
Thank you, Dr. Pagan. Hello, everyone. Nice to see you. I'm Deborah Brown. I'm the Senior Vice President for External and Regulatory Affairs. I'm going to be handing the bulk of the presentation over to my colleague, Okenfe Labarti, our Senior Director for Community Affairs. But I did want to start with, once again, a thank you to the board office, so many of our colleagues, and of course our team for their hard and ongoing work on this process. It is, as I've said, truly a pleasure to be part of a hospital system for which a community health needs assessment and a strategic plan are not just check the box exercises. They are part and parcel of what we do. And so a lot of what you will be hearing from Okenfe is really about the fact that this work is our ongoing and continuous work. It is not just an exercise for this purpose. Thank you very much, and thank you to Okenfe for leading this work.
Thanks, Deb. Before I begin, let me also quickly extend a quick shout out to Iman Sani and, of course, Rachel Larkin, two of our project managers that also worked on this report for the past 10 months that we'll be doing this.
It's intense.
So they have been really, really helpful. So, looking at this slide just gives you a quick recap in terms of what we did back in June, what the 2022 Community Health Needs Assessment was, our focus areas, the community by the communities that we served, and how we assessed our priority health needs both on the patient population that we serve and, of course, the larger community. And moving forward, looking at FY22 to 25, the implementation strategy is talking about the actions that the system as a whole is going to use in implementing what we have on the community health needs assessment. And I think when folks begin to read our implementation strategy, they are going to realize that as Deb mentioned, that a lot of work and a lot of effort really went into this. Next slide. And this is just a sample of the report, the CHNA that was voted on in June. Next slide. Thank you. And so as we begin to do a deep dive into the priority health needs and the implementation plan, and looking at the three main focus areas, which was improving health equity, fighting chronic disease, and facilitating access to resources. As you read this, I think what people are going to realize is that, especially for us, that issues around improving health equity, it's not just a buzzword, right? It is something that we focus on as a system. It is part and parcel of what we have been doing for a while. And so when they look at our priority health areas and how it ties into our strategic framework, they will also see that it's a lot of work, it's a lot of efforts, and there is an intentional design in terms of how all this was put together. Next slide. And so, after you approved the report in June, I think the team maybe got like a 2 weeks break, and then got back to work on this implementation plan. And so, what we did was to basically catalog the hundreds of programs that we have both at the system-wide level and also at the facility level, catalog all these programs, and then work in partnership with our facility CEOs, our SVPs, and sent them a huge Excel sheet and said, look, these are the programs and the initiatives that as a system that we are working on, and we want you to take a look at these programs and then see how they all fit into the priority health needs. That not necessarily those priority health needs were chosen by the team, but it was chosen by the community, and of course, New Yorkers as a whole, with the 30,000 plus survey response that we received. And what has been really interesting about this process has been the level of coordination amongst us at the central office, the level of coordination with each at the facility level, the support that we received from our CEOs, and of course the community as a whole. And then, of course, working on the writing process and having that conversation with our facility team members to really get a good idea on how we're approaching this. So, of course, here we are today, doing the presentation, and after today, uh, we are going to continue the work that we started earlier on in I believe it was February or March, when we had the community health needs assessment advisory group that has really been guiding us and also giving us feedback. And for us, what literally sets this group apart is the fact that it has folks from the central office, it has folks from the facility level, it has people outside of the facility, it has our CAB members, our CAB chairs, it has people from all through the five borders. So they've all been able to work with us for the past 10 months to really put together, some of the things that we are seeing today. Next slide. Next slide. One more. Great. And so as you look into the report a little bit more, and Debbie can add anything you want as well. As you look into the report, you see that the way the report was designed intentionally was looking at these hundreds of transformative programs that we have in the system and then matching each of these programs with the priority health needs. So we were at South Brooklyn Health earlier today having an event with CMS, and all of a sudden CMS is doing their presentation, and they put up our community health needs assessment, using our community health needs assessment to do their own presentation. And so we're like, wait, where did this come from?
It was kind of a cool meta moment, but because this is a public document and because this is data that is useful and we've already used it in so many contexts, they put it into their own presentation. It's pretty great.
Yeah, which was really, really outstanding. Next slide. And so the more you go into the report, you see the fighting chronic diseases, talks about the goals and the tactics. And each of these goals and their tactics are pretty much guided by our strategic pillars. And so when you look at the strategic pillars, you look at our community health needs assessment, you look at the implementation plan, and all the way down to the programs that we have at the system, you really see how everything matches together.
And so what we want to be doing as you look at this work and as we engage on this work is think about, like, it's not just the individual program in isolation, it's the program as it addresses the identified community health need, or if it doesn't, how to make it better, and then how that moves up into our kind of system pyramid on what our strategic goals are.
Next slide. And so just stand on this slide quickly, which again goes to one of the things that we've done throughout this process was listening to a lot of people, getting their advices, getting their thoughts. And when we're having some of this conversation, I remember we had a conversation with with Fanny, and he said, look, all this huge program, how people are supposed to find out about it, and he gave us some ideas. And on the online version of the report, you see that we basically hyperlinked a lot of the programs. So when you go in the report, you click on each of these programs, it takes you to another website that gives you a lot more description of what the program is. So it's not just with folks searching for information, but now they have this information at their fingerprints. At their fingertips. Next slide. No.
Yeah, so one of the parts of the IRS requirements is to talk about what our resource commitment is. And again, this is a place in which this is, sort of self-evident, right? These are programs that are in place, that are coming online, that we will continue to sponsor and fund. So this is a matter of not just like the dollars investment, the resource investment, the staff investment, the in-kind investment. And one of the things, you might remember is the last time we did this process, there was a lot of disrupt funding in place. What we've been able to do, and kudos to Matt, kudos to so many of our program leads, is to really take those programs and to strategically kind of think about what is in the best interest of the system, what can we maintain, what advances our strategic goals. And those are continuing to be our investments to make sure that we are doing this work. And this is, something, as I've said before, it's not just, a couple dollars off to the side. This is the part and parcel of the work that we do. And then same as I said about the evaluation, it's such an important part to make sure that we are keeping our eyes not just on the individual program, which is something not just we do, but the program managers do, but also to think about how these programs fit into the strategic planning pyramid. And that's one of the reasons why in this conversation this year we worked it through the strategic planning committee, because it's really important that this work marry to the overall work, philosophical work of our system.
Next slide.
All right.
So the next couple of slides just give you a bit more ideas on what the report looks like. This is our strategic pillars. More. And so on this page, where and the page before that, some of the other things that we did was, yes, we have hundreds of transformative programs, but we also asked our CEOs, are there some programs that you really do want people to focus on, right? And so we have about 20 or 30 plus programs that we put a spotlight on, so that people can get a lot more information about that program, and of course working with the program leads to make sure that we, commit to the evaluation aspect, that we are working with them as well. And then on the previous page, no. So when you read, yes, when you read, take a look at this page, you see how each of the priority health needs mirrors the program at each of the facility. So you see on the left-hand side, you see the facility where the program is happening. If it's a program that's system-wide, you also see that's written system-wide. And then when you're looking at the online version, you'll be able to click on that program, and then it takes you to the website that has that information in case you need a lot more on, if you need additional information. And so, overall, I think we've listened to a lot of folks. We've gotten a lot of ideas together, and I think this has really been, this past 10 months has been interesting, wonderful.
And really, and just to quickly wrap up, this is very much living and breathing. And like, all kidding aside, the fact that we see this in the CMS presentation literally today speaks to that. This is not work that, we want to kind of leave off now. We're going to be continuing our advisory board. We're going to be continuing our work with the CABs, with the CRC committee, with the public meetings, everything that we need to do to ensure that we are getting public feedback. That is all, Mr. Chair. We're happy to take any questions.
Thank you so much for the presentation and for giving us a hard copy of the report. Really appreciate it. Any questions from board members?
I'd just like to comment on the work that has been done on the ground. And we'd like to hear back from you internally, if that's possible, on how the implementation is going.
For sure.
Yeah, I just wanted to comment on an excellent job well done, and how purposeful you've been in every intent on how you focused on every issue. I thought this was well put together. Thank you.
Thank you.
I just had one comment and question. Also impressed with the amount of work that went into it. A lot of times what we hear from communities is that they give a lot of feedback and then they don't get it reflected back about what the actions are going to be. You mentioned some of the meetings that are happening, but I'm curious kind of how this plan gets back to community members who really help to inform it.
No, it's a great question. And I mean, part of our public process is helpful in that regards, assuming that you all vote to approve this. This will immediately get posted on our website. There's an email address for which people can give information. We're going to keep pushing this out through our CABs, through the kind of built-in relationships that we have. We, are fortunate through a variety of our partners here to have significant relationships with CBOs. We send out a digest to a couple thousand people every week, so we'll include it in that. We're trying to scorch the earth as much as we can.
Right, and of course the advisory group meets every month. They've been meeting for about 10 months now, so that meeting, of course, is going to continue.
And I just want to thank both of you and the whole team that worked on this. I know this was massive amounts of work, and I like the way that you approach it by basically canvassing, speaking to everyone that you could within a limited period of time to gather all this information, and also of thinking about it more than just some sort of requirement that we need to do, regulatory, but by being ahead of the game. I mean, this is a living document, and I think that we're a step ahead of a lot of health systems, or most health systems, when it comes to addressing these needs. So thank you so much.
Thank you. Thank all of you. And I would, if it's okay, like to thank, in addition to the team members that we spoke about, Chris Philippou, Wilbur Yen, and our data team. And there's so many others who really were part of this process.
Thank you. Barbara?
Just one last question. You submitted this to the IRS, the original plan, and have they given you any feedback?
No, so it's a public posting, but it's not, sort of an interactive process.
Oh, I thought they
Yeah.
had to put a big stamp on it or
God,
something.
God bless if they were able to give specific feedback.
much
to every
work and
hospital
then-
yeah.
Okay.
So let me then move for a vote. Dr. Katz,
Yes.
Dr. Williams Eisen,
Yes.
Dr. Martone,
Yes.
Dr. Calamia,
Yes.
Karen San Hilaire,
Yes.
Dr. McCrae,
Yes.
Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñero, Frida Wan,
Yes.
Anita Kawatra,
Yes.
Dr. Morse,
Yes.
and Jose Pagan. Yes. So thank you so much.
Thank you.
And okay, so we move to the next agenda item, number 3, Ms. Wan.
Oh, sorry. This is a resolution authorizing New York City Health and Hospitals Corporation, the system, to sign 3-year agreements with each of Institute for Community Living, Inc., ICL, and Communalife, Inc., Communalife, for the provision by ICL of 26 respite beds and by Communalife of 25 such beds, with the system holding 2 one-year options to renew both contracts for an amount for the 2 contracts together not to exceed $17,960,500 over the potential 5-year terms. This was presented and discussed at Finance Committee on October 17th, 2022, and approved to bring to the full board. So, team would go ahead and take us through the presentation.
Sure. Next slide, please. Good afternoon. I'm just going to take 1 minute and talk a little bit about our Housing for Health initiative and how it connects to medical respite. New York City Health and Hospitals is working to secure housing, both permanent and interim, for our patients who are experiencing homelessness. That is 5% of our patients, and to date, we've successfully housed over 400 patients, and over 800 patients have benefited from our respite program that we're about to talk about. Respite is one of our strategies to permanently house and support our patients. The others are working with our sister agencies, using our land, and in some cases, funding permanent services in permanent housing. I'm going to turn it over to my colleague Marjorie, who's going to talk about the medical respite RFP, which furthers our initiative.
Thank you so much, Leora. Next slide, please. Good afternoon, everyone. I'm Marjorie Montplaisir-Ellis. I'm a Senior Director on the Housing for Health Initiative, and I'm here to talk to you about medical respite, which is very exciting work, and I'm really proud to be a member of this team and leading the contracts with our 2 providers. The problem that we sought to solve, the need that we have at health and hospitals, is that we have lots of patients who are experiencing homelessness, and because they have additional needs after being hospitalized, they're not able to go to shelter. So sometimes that means they need to be able to have oxygen, to be able to have wound care, they need to continue with physical therapy, and they're not able to do that, and what happens then is that they end up virtually living at health and hospitals so that they can continue to receive those services. So what this medical respite addresses is that need by providing interim housing for those individuals, having case managers and social workers at those sites be able to do intensive housing case management,
allowing our discharge planners to put those aftercare services into place so that those nurses and the physical therapists can come to the medical respite site and be able to provide the patients, the discharged patients that are there, the services that they need. This helps our system, this helps people, it helps us to be able to save cost and to be able to house people in more stable housing environments instead of remaining in the hospital. Next slide, please. So currently, we have two contracts. The contracts were initiated in 2019 with One City Health, Post-Acute, and other, and Population Health had contracts with these providers. In 2020, our Housing for Health initiative was able to bring all of those contracts into one place for management and to streamline the process. Currently, we have 51 beds, 26 that are operated by the Institute for Community Living, 25 operated by Communal Life. We operate at 90 to 100% capacity. As you would imagine, the need across our entire system is pretty high, and so there are no ancillary costs associated with these contracts. We are currently the biggest investors in medical respite in New York City. There are other healthcare systems who contract for medical respite beds, but none not as high as us with the 51 beds. Thank you. Next slide. We also have been fairly successful in our work in terms of being able to help people to go to a more stable place after being at medical respite. You'll see here that 35% of the people who go to respite are able to then go into more permanent housing, including supportive housing and family reunification, assisted living facilities, and other things that if our social workers, who are extremely overworked within our system, if they had more time, they would be able to do. But through medical respite, we're able to provide this service to our discharged patients. Next slide, please. Currently, the average cost of a contract of a bed is $150 per bed per day. We know that because people are able to be discharged sooner, we're able to fill those beds with other individuals who are then able to fill that need and have their health care being taken care of. This overall translates to an estimated net revenue of $16 million, because if we estimate that when those individuals leave and we have 950 new people being able to take up those beds, we're able to get that revenue from them leaving. Next slide, please. This is the RFP criteria. Basically, we were looking for people who are nonprofit organizations, not people organizations themselves, who had experience doing this work. We also wanted to make sure that their ability to connect people to housing, we wanted to make sure that they had that experience as well, so that we would continue to help the patients who get discharged there. And you have in front of you the criteria as well as the evaluation committee who were part of this process. The MWE requirement is non-applicable for these vendors because these are two community-based organizations, but there is information about their workforce diversity included in your slide deck for you. Next slide, please. This is the procurement process. We did have 12 potential vendors, attend the pre-proposal conference. Many of them were just very, very curious about how the process operates and how we intended to pay for these services. And in the end, we received two proposals. The two proposals are from our current vendors, and they were evaluated, and based on their scoring tabulations, both Institute for Community Living and Communal Life were found to be satisfactory vendors that we would like to be able to proceed with. Next slide, please. So we currently have, the contracts are ending on November 30th. What we are seeking to do is to be able to have a 3-year contract in place beginning December 1st, so that the vendors can have the real estate and be able to have some stability in the permanency of this program. And we have also added additional services. In this new contract, we are requiring that the two vendors have a registered nurse on site 2 or 3 days a week. We've also been successful in helping them to be able to connect to our medical record through Epic using Epic Care Link. So now they have access to the information about the individuals who are now at respite, and so they can coordinate their appointments and help them to follow up on treatment after they are at respite. And they are also being connected to Express Care so that people who are at respite who need that service can also access it. Next slide, please. The performance evaluation are there. Next slide. For both of the vendors. And that's it. Thank you.
Thank you so much. Any questions from, go ahead, sir.
I just have a couple of questions. And yeah, it's really just for a better understanding of the cost. You say the investment in medical respite directly avoided an estimated $17 million in hospital operating costs. Would that be the cost of having homeless, ill patients as patients long-term in the system?
We had at the committee meeting a long discussion about how complicated it is to estimate the actual savings.
Right.
Because the savings entirely depends upon what is the reimbursement we're getting for the patient in the hospital. And you have to know that, and you have to know what would be the replacement revenue, right? So if you say it's an uninsured person, you open a bed and another uninsured person comes, right? Versus uninsured and then there's a paying patient come, and whether it's a DRG diagnosis, right, where you get paid the same amount regardless of how long they stay, or whether or not we're getting ongoing payments. But at this point, our system access is such an important issue for us with the workforce, right? That we don't have enough nurses and doctors. And so moving people out of the hospital will certainly improve access. And to the extent that we shorten the length of stay and more people are within their DRG amounts, or we're getting a higher per diem, we should be able to get the dollars. It should balance itself. I mean, I think that's and the good thing is the team is prepared to now calculate this going forward. So while we can only project it, and John has done his best to project it based on our payer mix and the best assessments that it'll be balanced. But I think what would be really interesting will be to see what it is in 6 months, because they'll tell you who are the people they moved, and they'll tell you what the return payer mix was.
And the estimated net revenue of $16 million, that's annual, right?
Yes.
And do you net out from that the clinical costs of sending in medical providers to the facilities?
Typically, those medical providers that are going to the facilities are contracted either through our CHA, and they're paid through Medicaid for that. The cost of the aftercare services are not part of the budget for medical respite operations.
Okay, thank you. Those are my questions.
Barbara?
Just to piggyback on what you presented, Dr. Katz, I'm interested also to know how well, in a sort of long-term way, we've produced a savings based on the care we give, and whether people kind of fall back into illness and disappear from us for a while, and mortality rates.
Sure.
Yeah, those are kind of hard to always put together, but I know that we talk about our success from the fact that we do the work while they're in front of us, and in any given community, if there's increases in mortality that could have been prevented, then how do we grapple with that?
Sure. Well, it's a great question and an important issue. Going forward, we will have great data. And in general, the national data shows that housing people does decrease their mortality, and that the groups with the highest mortality are street homeless, people who have really a horrifically high level of death. And it's, due to lack of medical care, it's due to exposure, inadequate clothing in very cold weather, which the season we are now going into. Bless you. So with this program, we'll be able to capture exactly what the outcomes are of the people that we care for. We've, in programs like this, we've had a high rate of permanent housing because we have enough time. And often we can even move people to other settings because in this respite they improve enough. So someone might not qualify for a program at the time they go to the respite, but after they've been in the respite for a little while, they might qualify for the program. So I think all of these things together will help us on the mortality.
Thank you.
Thank you.
Just along those lines, Mitch, I think if we have the ability to capture this, and we talked about this at Finance Committee, to being able to get people permanently housed and all the ancillary things that actually occur from this, and then even tracking the cost analysis, I think that would be really compelling to.
Right. We will. It'll be very interesting.
Calamia?
Thank you.
Yeah, just along those same lines, with respect to the services that are going to arrange those things, the permanent housing, a lot of these people are homeless for a reason, whether it's mental health or addiction and so on. What other services besides an RN are really being provided, or are we providing all of those? And again, I think the follow-up and seeing exactly what the outcomes of these are going to be would be really super if we can get that information back. But anyway, with respect to other services, anything that they're providing, or are we providing, for example, the arrangement for permanent housing and so on?
Absolutely. So while people are at respite, they have a housing specialist who's working on the housing front, but also case managers and care coordinators that are making sure that people are coming back to H&H for their appointments, that they're following up with the care that the discharge planners have put in place for them, as well as medication monitoring. So they're not licensed clinicians on site, so they can't administer the medication, but they will, from 8 to 10 for your first dose, remind everyone to come down, and they store all of the medication appropriately so that people are reminded and could take their medication. We do have quite a bit of referrals for folks who are, after being discharged, that is the key thing that their provider wants the medical respite provider to do, is to help get this person in the habit of taking their medication and having the appropriate storage place for them. We are extremely excited about following up about all of the people who go to medical respite, and for our entire housing team, as people get placed into housing, we are extremely concerned about making sure that they stay housed and that they live their healthiest lives. So this is something, the data, the tracking, the being able to speak to what happens afterwards is something that we're keenly interested in and will be following up on.
Okay. Any, please.
As I'm sure you're acutely aware, the state recently put out a proposal in this space. How do you see that changing any of this programmatically and/or impacting your ability? Like, would you be able to use that revenue for that, or use that program to kind of support this?
Sure. So the regulations were released, the proposed regulations were released on October 19th. Today is October 27th. So we are still reviewing them, and we do have a 60-day period in which to respond. But based on our initial reading of the regs, they are not extremely stringent. They seem to be focused on the physical space, and the programmatic recommendations that they make are very vague in general. And they haven't spoken directly about the billable aspect of this work from the managed care organizations, which is something that we are hoping for and something that we desire to see change. So we will be having conversations as well about that.
Okay, one more question.
Thank you very much. I noticed on page 6, the medical respite program, when you receive your referrals from 15 facilities that 2 of them are located in the Bronx, Jacoby and Lincoln, which are our largest facilities. Have you yet figured out as to why is there a large amount of homelessness in Bronx County that wind up going to Bronx hospitals that eventually then wind up in your program? And we're talking about a very small number of beds. I wonder if you had come to that conclusion, which is what I felt, but I really would rather have it from the medical professionals.
Thank you for calling us medical professionals. I think there are a few factors at play here. I think because the current beds are in Upper Manhattan, and when we interview, as part of the assessment process to go to medical respite, we interview folks who are at Elmhurst, who are at Queens Hospital, and when they find out that they would have to go all the way to Upper Manhattan, then they're not interested because all of their support systems are in Queens or in
Yes.
Brooklyn. So I think that the location of the medical respite facilities would definitely play into the fact that we have more referrals from those 2 facilities. The other part of it too, I think, is that the discharge planners have come to know medical respite and have spread the word among their colleagues, and so they're more familiar with medical respite and are able to make the referrals. But I also think that you are correct, sir, about the fact that there is a huge population of people experiencing homelessness, particularly that go to Lincoln Hospital, especially because it is so close to wonderful transportation and a lot of structural things happening in that community, that we also see a lot of homelessness at Lincoln.
Okay, thank you very much. I appreciate it.
I would like to add that some of the people in the Bronx are really transients from another state.
Okay, so let me ask for a vote. Before I do that, I want to state for the record that Erin Kelly is representing Deputy Mayor Ann Williams Sison since the beginning of this resolution. So, so let me ask for a vote then, and welcome. Dr. Katz,
Yes.
Erin Kelly,
Yes.
Dr. Martone,
Yes.
Dr. Calamia,
Yes.
Karen St. Hilaire,
Yes.
Dr. McCray,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes.
Frida Wan,
Yes.
Anita Kawatra,
Yes.
Dr. Morse,
Yes.
and Sapagan, yes. Thank you so much.
Thank you.
Thank you.
So we got 2 more, so let me move on. Number 4 on your agenda, authorizing the New York City Health and Hospitals Corporation, the system, to execute 5-year revocable license agreements with each of Metro PCS, Wireless Inc., Metro PCS, and with T-Mobile Northeast LLC to operate cellular communication systems on approximately 200 square feet of space on the roof of the AC building and 200 square feet of space on the roof of the A building, respectively, on the campus of NYC Health and Hospitals Kohler Rehabilitation and Nursing Care Center, at annual occupancy fees for each site of $74,500, calculated as $372.50 per square foot, to be escalated by 3% per year for a 5-year total of the 2 licensees together of $791,061. This was presented to the Capital Committee on September 17, 2022.
Hello again. And talking about cell towers. At Kohler, there are 2 cell towers on the campus, on the A and the AC building. And they each have different radiuses for the city. In the next slide, please. In 2017, the board authorized 2 5-year license agreements for both T-Mobile and Metro PCS for occupancy of 200 square feet on the roofs of each building. The agreements either have recently expired or will expire imminently. We wish to continue those agreements. Both entities are now business units of T-Mobile, so they're both with T-Mobile. The new terms are now the same and co-terminus, so both the T-Mobile and the Metro PCS agreement will each pay $74,500 per year, with the combined 5-year total of $791,061. The new agreements will commence December 1st. There will be 2 agreements, and cell towers, it's not typical to get a fair market analysis, but we have a few towers on our campuses, and this is in line. On the next slide, please. This is a summary of the occupancy fee, which we just discussed, and that's it.
Okay, any questions on cell towers?
That's so technical.
Let me ask for a vote then. Any questions? No. Okay, so Dr. Katz,
Yes.
Erin Kelly,
Yes.
Dr. Martone,
Yes.
Dr. Calamia,
Yes.
Karen San Hilaire,
Yes.
Dr. McCray,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro, Rita Wang,
Yes.
Anita Kawatra,
Yes.
and Dr. Morse,
Yes.
and Jose Pagan, yes. So thank you so much. So resolution. The next one here, number 5. Authorizing New York City Health and Hospitals Corporation, the system, to execute an agreement with STV Inc. to design the flood mitigation system to be constructed at NYC Health and Hospitals Kohler Rehabilitation and Nursing Facility for a cost not to exceed $7,930,000, inclusive of a 20% contingency of $1,320,604 contingency over a term to be coextensive with the duration of the project, which is estimated to be 8 years. This was presented to the Capital Committee on October 17th, 2022.
Good afternoon, everybody. I am Manny Saya, Senior AVP for the Office of Facilities Development, and I'm accompanied today by my colleague, Senior AVP for Capital Design, and also our Senior Director, Aniqua Brown. And this is a request to enter into contract with STV Inc. for New York City Health and Hospitals Kohler FEMA Flood Exterior Mitigation Project. And with that, I want to hand it off to Oscar Gonzalez.
Thank you, Manny, and thank you, Mr. Chair and board members. There's been a lot of discussions lately about Sandy and the anniversary, so I'm pleased to say that we do have a lot of history with the FEMA program. We were able to get a lot of allocation because of all the damages that Sandy caused at our facilities, specifically for Coney, Metropolitan, Bellevue, and Kohler. Kohler, which sits at the north end of Roosevelt Island, was heavily impacted because it sits at the 100-year floodplain. 100-year floodplain. It was left without electricity, heat, hot water. So major repairs, enhancements, and mitigation solutions were needed to be figured out. One of those solutions was an exterior flood protection system. It needs to be designed, for the facility to meet the 500-year floodplain. So out of the entire FEMA program of $1.8 billion, this would be about $98 million worth of design and construction work that's been allocated towards this FEMA protection wall. So we've started the procurement to get the design going and the construction. And with that, I'm going to hand it over to Senior Director Aniqua Brown to talk about the procurement.
Thank you, Oscar. Good afternoon, everyone. So because we're coming upon the 10-year anniversary of Sandy, we did a quite expeditious procurement time frame in which it took about 6 weeks to go out, request an RFP, and then actually select a vendor. So with that, we went out with the RFP in early July, actually did pre-proposal conferences and walked on site with the various proposers throughout July, and the proposals were due in early August.
With that, we proceeded with vendor presentations in early September. Of the 14 vendors that came on site and the 26 that attended the pre-proposal conference, we received the 4 proposals. That wasn't a surprise with the level of complexity that's involved with building this flood mitigation program. And so with that, the vendors presented in early July. We evaluated the different proposals and then selected someone in mid-September, just 6 weeks later. Next slide, please. With that, the RFP criteria consisted of the proposals needed to have at least 5 years of experience in designing flood mitigation projects, as well as having experience in a healthcare setting. They had to be a licensed professional with a New York State license and had to meet our MWBE goals. The substantive criteria consisted of 25% appropriateness in the quality of their experience. 25% relied on the qualifications of the consultants and their staff. 20% was based on their approach, how they were going to approach the project and their methodology. 15% was based on their MWBE utilization plan, and we'll see later that they've actually exceeded what we proposed. And 15% was based on the cost. Our evaluation committee consisted of 5 people, which included 3 representatives from OFD, someone to represent COLA's interests, and then the 5th person was from our fiscal affairs department. In terms of the project information, we're looking to enter into a contract with STV to provide design services for the COLA exterior mitigation project. The funding for this project is with FEMA, is using a FEMA grant. In terms of the budget breakdown, the design cost is about $6.6 million, with 20% contingency at around $1.3 million, totaling close to $8 million. We realize that the 20% contingency is typically higher than what you would see, but based on the length of this project and the complexities that we anticipate experiencing, along with the various regulatory affairs and departments that we have to work with, including FEMA and REOC, who owns the property, we feel like the 20% is suitable for the issues that we may be up against. In terms of the schedule, we're looking for the contract to be extended to include the full completion of the project. We anticipate that it'll only be 2 years for the actual design, but it'll take about a year for procurement, 3 years for the actual construction of this berm, and then 2 years for closeout. So the actual contract will end up being approximately 8 years is what we're anticipating right now, while only 2 years of that will be for the design. Next slide, please. In terms of vendor performance, STV included in proposal, and we've identified that they have worked on more than 65 Sandy recovery projects. And they have received the second largest FEMA award for public assistance. STV doesn't have any direct contracts with H&H to date, but they certainly have worked with us as sub-consultants, and they have worked with other city agencies as well. With that, we checked into the mock system, and we have 106 previous evaluations that we were able to capture. Of that, the majority of the evaluations were satisfactory or better, with 2 of them being unsatisfactory. One of those 2 was back almost 20 years ago from DCAS. The second was back only about 2 years ago from DEP. We did manage to follow up with them, and we're happy to report that when we did follow up, that representative that completed their evaluation said that they replaced that staff and the performance has significantly improved. So they have been able to maintain that contract with the person that had that negative evaluation and have improved and turned that around. Next slide, please. In terms of MWB utilization, we invited 2 MWBEs and 5 non-MWBEs. But as mentioned before, this is quite a complicated project, so it wasn't a surprise that a MWBE firm wasn't able to support or provide a proposal as the lead designer. However, STV has been able to propose that they're looking to include up to 34%, as far minimum 34% in terms of MWBE participation, which is above which was above the requirement. Next slide, please. And again, so the request is to enter into contract with STV for $7.9 million, inclusive of a 20% contingency of $1,320,604, with duration to be coextensive with the duration of the project.
So much. Any questions for board members?
I just have one comment and appreciate, we talked about this in Capital Committee. Thank you for the diligence that you guys did and also for explaining the somewhat larger contingency. I think the one other question I had, if you could just clarify that this seems like it's a design contract, so you wouldn't expect that there's a lot of, back and forth and so uncertainty with the contingency, but I think you explained there's other aspects that they do, which would.
If the majority is going to be design, but then we're gonna need to have that support during the procurement process as we're bringing on the builder. The builder is going to have a lot of questions. They're called RFIs, and the consultant is going to have to answer those questions. Once the builder is on board, there's going to be additional questions and a lot of unforeseen conditions where the designer is going to have to get engaged, and ultimately the designer will have to ensure that the vision of that design is being implemented properly by the builder. So that's why they have to stay all along the track of the
Right, so there could be a lot additional work, redesign, things like
a
that.
lot of additional work
Yep.
that they have to work together on.
Great, thank
And
you.
then, and then there's obviously the process of the closeout as well. So once we're closing everything out, it's closing out all the books with the vendors, but also closing out all the books with FEMA because we want to make sure that this is FEMA certified at the end of the day.
Right, there's a lot more complexity there. Yep. Okay, thank you.
Any other questions? So let me ask for a vote. Dr. Katz?
Yes.
Erin Kelly?
Yes.
Dr. Marcel? Yes. Dr. Calamia?
Yes.
Karen San Hilaire?
Yes.
Dr. McCray?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Maria Hernandez Piñero?
Yes.
Rita Wang?
Yes.
Anita Kawatra?
Yes.
Morse?
Yes.
Mr. Pagan, yes. So thank you so much.
Thank you.
So now is President's report, Dr. Katz.
Thank you, Mr. Chair. Well, the coronavirus update, perhaps the most important update is how great it is to all be together in a room. We're still wearing masks, but at least we're all together. We're going to distribute 10,000 COVID at home kits that are more accessible for New Yorkers who are blind or have low vision. That's an important part of making sure that there's sufficient access. If you're sight impaired, you're not going to be able to read those skinny little lines to know the result of the test. We are preparing for a difficult flu season. I know Dr. Morse, our sister agency, they're doing everything they can to promote flu vaccine, to promote COVID bivalent vaccines, as are we, to our staff, which you heard some about, to our patients. We're very actively pushing getting one vaccine in each arm to try to get it done within the same day. We've been very active on helping the asylum seekers in New York. We are currently running a large hotel for families. We are running, providing the services at an emergency tent shelter for single male adults. In both places, we're providing medical care, hot meals, phones to call family members, to connect people. Our Department of Education is connecting children to school and other resettlement services to help people to accommodate to the U.S. And I think it's an important part of Health and Hospitals' commitment that we will always help people and provide what they need regardless of their immigration status. We concluded the year doing our analysis about our spend for our program for minority and women-owned businesses. This has been a major issue for this board, and I hope the board is very proud of itself and Health and Hospitals, because we're showing a 3,000% growth in spending from 2017. So in the 5-year period, 3,000% growth. We're currently at $747 million going to MWBE businesses, and that's actual money out the door. We don't, sometimes people track awards, and awards may not actually represent dollars because the people may not actually spend the full award. This is actually dollars out the door. It's 32% of all of our spending. And I think it really reflects well on this board, on the department, on our purchasing department that really sees this as a key strategy for achieving equity, diversity, and inclusion. We're very proud of it. We have a program for honoring our nurse scholars. This has been, I know, a major issue for Barbara Lowe, who always talks about getting our nurses out in the academic world and having them present their research. So we're very proud that now we have 72 nurses with doctoral level degrees, nurses who have pursued their education to the very highest level and are able to handle the complex problems that we have at health. We recognize Hispanic Heritage Month with our great pride in our staff who are of Hispanic or Latin origin and the number of patients that we care for. And we see this as a vital part of our inclusive service system. I wanted to note that we were also on the nursing side, that we were at Kings County to celebrate that Kings County earned the coveted Pathway to Excellent designation for its commitment to nursing. This is the first hospital in Brooklyn to receive it, and only the second facility in New York City. So, and I don't mean second public hospital, I mean second hospital of any of the hospitals in New York. It is very challenging, and I particularly admire the criteria, because the criteria are all about nurse empowerment. It's all about whether the individual nurses feel that they can influence the care that each patient receives, that they are empowered to say what should happen, that they are consulted in all aspects of the decision making. And there was also, when we were at Kings County, the nurses were incredibly proud. They did a dance on stage, and I still remember the chorus, because I thought the chorus would be a good thing to remember for any of us in life. The chorus was, "We're on a journey, I care." We're on a journey, I care. And I thought that would be applicable to almost anything that we did. South Brooklyn Health celebrated the future opening of the Ruth Bader Ginsburg Hospital with the bronze statue of Ruth Bader Ginsburg, which we all love, since she was a small but incredibly powerful person, represented her 100 pounds and I think 2,500 pounds of bronze. So it was a nice way to celebrate her. Queens Hospital is doing its first program to train people to do at-home dialysis. You don't hear about it, but this is also a disparities issue. That home dialysis is better than getting dialysis at a center, but there have been certain assumptions made about who is capable of doing it, and what social situation is necessary, and who has the intellectual ability to do it. And the result of those assumptions has been that more minority persons, low-income persons are sent to dialysis centers, and nobody really talks to them about how doing home dialysis is safer and better. People just assume that they wouldn't be able to do it, and we're starting in Queens to show people that that's not at all the case. We were in front of the Bellevue gates with Senator Gillibrand last week to announce the One Health Security Act legislation that she's carrying, that we hope will make a big difference in this country's readiness for future pandemics or man-made attacks. And I was also out in the Rockaways with Council Member Brooks Powers, uh, announcing her task force on trauma and healthcare access out in the Rockaways. So lots of great things happening at health and hospitals, and lots of reasons for board members to feel incredibly proud of the amazing women and men who work for us. Thank you.
Thank you.
Go ahead.
If I may, for Dr. Katz, I know that you are always looking ahead, months and months ahead and years ahead, for all the possible emergencies that could befell our system. So I know that you are, I saw during the week that the pediatric emergency beds in Rhode Island was at 99%. I think Missouri was 98. There was another state to the west of that was at 97. I have no idea where we are, but I guess we're not anywhere near that yet. But you must have other contingency plans in place through your CEOs in past years, because I know you, Mitch, and I know that if it's Mitch, Mr. Contingency Katz. I know you are always prepared for the next, battle that we're going to have to face. So could you just give us an update
Sure.
on that and where you are?
Thanks, Bob, and thanks for the comment. So yes, you're right on all counts. You're right that many states have been hit by very high numbers of children needing hospitalization, mostly RSV related. Nobody's quite sure why we've been spared at this moment and whether that will change. But right now, while we have kids with RSV, we just don't have the number. But you're right, we showed in COVID we're quite ready to flip beds, to draw in more staff if that becomes necessary. We absolutely will. But so far, we're okay on the kids' beds.
Thank you very much.
We'll keep the board notified if things change.
I just have a question.
Yeah.
You may know the answer to this or not, but this renal at-home dialysis is extraordinary. It just provides great flexibility and options for people. Do you know if there are any public dialysis centers of this type elsewhere? It just seems very groundbreaking to me.
Well, when you say centers, right, what you need are good nurse teachers, and you need the adequate suppliers. But you don't need a center, right, because they're not going to go anywhere. So it's all about, there is a certain, you have to teach people, because many people have never heard of it. And on the first hearing, some people might squeamishly say, oh no, I don't think I could do that. Because it involves, and I don't know how much you know about it, but maybe other people don't. It involves putting a catheter into your abdomen. And then you connect yourself via the catheter to the bags of fluid going in and the bags of fluid going out. And your peritoneum serves as a natural filter. I mean, it's pretty cool when you think that God created us in this spectacular way, where we can use our own body to put fluid in and pull fluid out, almost exactly like the machines we taught to do that through dialysis. But the big things are, to help somebody who may have limited English, be Spanish speaking, not have much experience with the healthcare, to see why this would be better, to explain, why it causes less fluid shifts and therefore is safer for them, and that will provide the necessary backup, the fluids for them. So you don't need a center, and again, the technique very well established. It's just that it is typically very highly educated people who've heard about this or have resources to get somebody to help them, who have been offered this option, and everybody else is sent, to the dialysis center without even asking them, well, maybe you would like to do this procedure.
Thank you.
Do you know offhand as far as reimbursement? Obviously, every, share in a dialysis center is reimbursed by Medicare. Is it of interest to nephrologists to make sure they're referring these patients? And are we doing that, or are we sort of encouraging
Sure.
within our system to make that effort?
Well, you're absolutely right, Vince, that one of the things that pushes the dialysis center is the money. But Medicare will pay for all of the expenses of this, so it's not like we're losing any money. I think that there's been concern that for at least some of the dialysis centers owned by nephrologists, that there is a powerful incentive for them. Although, because modern American medicine is always sadly based on money, there are also ways of making money off the fluids, right, that people pursue. So, leave it to American medicine to figure out how to make money. But at least in our case, it's not an obstacle for us. And we have the patient in front of us, so we can, in fact, get them and provide the service and have it be reimbursed. Go ahead, Michelle, maybe you have more to add.
It sounds like we're just on this dialysis theme, so I think it's very exciting. And it's extremely empowering for patients to be able to do this at home, no matter their education and language. And so it's very exciting that you all are focusing on this. The question I was going to put forward actually is how are you thinking about connecting folks to transplant evaluation at the same time? And I know that we don't have a transplant center within H&H, which is okay. But I know that because of a lot of the changes, and you guys have talked a lot about this as well and changed it within H&H, many more Black patients are now going to qualify for transplant evaluation and referral
Yes.
in a more timely way because of the changes you've made with kidney function calculations and the race adjustment issue.
Sure.
So I'm just curious if that's a part of the conversation or if it's too early.
No, it's not. It is. I think our centers have been pretty good from talking to people about connecting our patients to the centers. And there's been, I know, is it One New York? What is the?
No.
Live On New York, thank you. Was very proud to show their recent increase in the number of transplants done for African Americans, where before the numbers were disappointing. So from just talking to them, they feel that things are good with us sending people for referrals. But I would much rather people have this home dialysis while they're waiting, and they will be safer during that time. So the two work well together.
I think there may be some studies out of Switzerland. I once heard the founder of IHI, when he was down at Medicaid, speak at a conference, his IHI conference, about the experience in Switzerland and how successful that has been.
Yes.
That's a while back.
Right.
So I think we should look forward to some very good results.
I think you're right, Barbara. I mean, the other Western European democracies have done better than we have on sort of using lower cost, higher effectiveness. And this is a perfect example of something that's lower cost and more effective, and offers a lot of flexibility to the person, right? They don't have to be at a dialysis center 3 times a week, and you can still go to work, and you can have an entirely, normal, I shouldn't say normal, you can have an entirely happy, productive life.
That's right.
Who knows what normal is?
Anymore.
I'd like to say a couple of things. One is you know, the board has been working really hard on MWBE for the last, since we, I mean, for the last 5 years at least, 4 years, and it's very impressive to see the numbers that we have been able to achieve. So congratulations to all of us, but especially all the staff that work really hard to make this happen, because we know how hard we think we know how hard it is, but I know it's really hard. So congratulations. The other comment was connected to, very impressed with this whole issue of nurses practicing at the highest level, and the fact that we have 72 of them that have graduate degrees, PhDs, DMPs, and so on. With all the changes in healthcare systems now, and how complexity of care, you talk a little bit about in your report there, but can we engage them even more now that they have these degrees and they belong to the circle, to help us envision how our system should look like in the future?
Absolutely, and I know, right, among our PhD nurses are our chief nurse officer, Natalia Sineas, and this is an area that she's really interested in. I know she was a big pusher of them getting the pathway to excellence criteria at King's, and we'll keep working on it and bring people in for these kinds of growth opportunities.
So I'm not looking for the next theme, but I'm just throwing the idea there.
I appreciate it.
Thank you so much.
Thank you all.
So let me see, there's one more thing. The committee and subsidiary reports were emailed to you and are in the folders for your review and submission into the record. Is there any old or new business to come before this board? Hearing none, then the meeting is adjourned. Thank you so much.
Thank you.
Thank you. Look at you.
This meeting is no longer being
4:18.
recorded.
4:18.